Go.
Yeah.
Okay. Thank you for attending this session, everybody. I'm just going to talk to you just for 5 minutes, hopefully, on the introduction of forum theatre within our specialist community public health nursing programme within the School of Healthcare Sciences. It's a postgraduate programme, and we train nurses and midwives to become health visitors. Just to put that into some context. I don't do this alone. My colleagues are with me today. Diana D is sat at the front. She's waving to you from there. And Kate Phillips, she can't stand because she's hurt her foot, is on the crutch there. And just some acknowledgement to Joanne Owen, who's from our simulation team, who does a fantastic job of moulage. So we're trying to simulate an honour-based violence situation. Health visitors deal with families aged 0 to 5 with a whole range of complex issues. It's quite an in-depth role, and this sits within our Safeguarding Children module, which I manage. And we just felt we needed to be a little bit more innovative in exposing our students to complex situations. So they deal with a whole range of child protection issues, from domestic abuse to all range of physical, psychological, sexual abuse issues. But one of the difficult things they're exposed to is identification of honour-based violence and the very different way in which you deal with it as a practitioner. So we devised a scenario. I first saw this being an example of this given at a previous conference, and we just found it I just found it very useful to depict and to challenge professional curiosity in such complex situations. So we put the scenario together. We met up. Diana does a session with them prior to this around culture, around female genital mutilation. When we think of honour-based violence, it covers FGM, it covers domestic abuse, it covers actually murder. Of women and men. So we thought very carefully around the planning of it, and we came up with using moulage and simulating this within a classroom. Space and resources are very limited, as you're probably all aware of. So you'll see on my next few slides how we simulate this within the classroom setting. So Joanna's come, and you'll see here, this is a burn simulated, and then a bruise on the wrist, which Kate very cleverly covers up with a pashmina, and you'll see that in a second. And then on the other photo, she's putting a slap mark on her face, and again, Kate covers it up very nicely with a pashmina. And identification and asking that question when somebody has a bruise or an injury is quite a difficult thing to do for a practitioner, whether you're a qualified nurse or midwife or any practitioner actually working within the healthcare setting or anywhere, because safeguarding, of course, is everyone's responsibility. So we should be asking, and research tells us that we should be asking. So we're trying to depict that within our sessions. So you'll see myself there. So I play the health visitor. Diana plays the very convincing, controlling, manipulative mother-in-law. She does it very well. She's very scary. But these are some of the situations that our students go into. And you'll see the scenario. That's actually in the middle of the classroom. I'll show you how that is set out in a second. But it's just an initial visit. Our scenario is that this mum hasn't turned up to clinic for a weight check. So I'm going in as the health visitor just to see how things are going, because there's been, there's a few concerns. I think sometimes your gut instinct is important as well. So that's how the scenario plays out. Forum theatre is a very powerful educational tool, and it's been around since the 70s, 80s, especially to expose students to safeguarding issues, challenging issues. It develops professional curiosity. It develops cultural safety as well. I put there in nurse education, but that covers all other areas of education. But developing those clinical skills, simulation is very effective in doing that. And when we're talking about honour, it's a very difficult concept to put across, so this is how we depict it within our safeguarding module. Okay, so you'll see here, actually the classroom is in Eastgate House, so our students sit around us and we're sort of in the middle of the classroom. And you'll see here that some of our students have stepped in. So I play the situation out not in an incorrect way, but I could be a little bit more prying with the mother of this baby. I sort of ignore the bruise. And I sort of play things just a little bit, I sort of step back. I try and get Diana as the grandmother to go out of the room so I can question the mother. And that's a really hard feat to get Diana out of the room. So it's getting the students to try and think, how can I get this victim on their own? And I step out of my role as the health visitor, and within Forum Theatre, I become the master of ceremonies, almost like the court jester that is depicted in some of the articles, and I then facilitate the session. So we talk about, what could have been done anything better, and the students say, well, actually, and then as soon as they put their hand up, I say, right, come and show us. So we get them to come in, step into the situation, and you'll see some of our students stepping in to the situation just at the top there, and they run it through again. So we start again, or they'll pick up from where I've left, or they'll just choose one area just to practice what it is like dealing with asking that question of, are you safe? Are you being treated nicely? Are you looked after? Can we get you to clinic? So lots of tactics to get them to the GP surgery or out. One of the questions is, would you leave? Would you leave this situation? And if not, what would you do? So we have a lot of discussion. So the debrief session allows us to look at how we would make this person safe within this situation. We recap what honour is, the complexity of honour and honour-based violence. It's not just about culture or religion. We offer lots of different aspects and lots of different solutions to this very, very difficult situation. We signpost them to not involving to different organisations, and actually not involving family members within this, because this would put the victim at more risk. How am I looking for time? I'm done. Okay. Oh, okay. Just as one quick second, some students don't like this at all, and we've evaluated it over the last 2 years, and we're in the middle of writing up a paper around it. So watch this space. I've provided you with some references. That's it.
Thanks, Michelle. We've got Christine Munro and Claire Hawker as well from Healthcare up next.
Is it just on OneDrive, yeah? Yeah, here. 3. We could try somebody else's presentation, couldn't we? Mix it up a bit, Okay. Okay, I'm not actually on the schedule, but I'm a nice surprise. I'm... for you, maybe not. I'm Director of Simulation and Technology in the School of Healthcare Sciences, and about 3 years ago I got involved in this ISPAD project, and I'm going to refer to it as the ISPAD project. Basically, it's an Erasmus-funded simulation project. So I'm going to tell you a little bit about the context of this project. So the aim of this project was to plan, develop, test, evaluate and disseminate a simulation kit for undergraduate nurses, and it was a project that involved quite a few European countries, as you can see. It involved 20 nurse educators, so quite a few, coming together. We had 4 transnational meetings to move this project forward. We started in September 2016 and it finished in August 2019. The University of Malta was the lead project partner in this, and basically we worked in triads, so 3 triads, to try and develop these 3 resources. So we were tasked to develop the Year 1 SimKit simulation resource, and we worked alongside an Italian university, the University of Molise, and Turku in Finland. So we were quite lucky doing the first year one because actually we could actually lead the way a little bit. There was lots of discussion, as you can imagine. This sim kit had to have international relevance and currency across countries. So it was hard. There was a lot of discussion about what the focus of these 3 simulation resources would be. And I kind of steered the group into thinking a little bit about community simulation because of my experience is that a lot of simulation tends to focus on the acute setting and tends to be steered towards the background of lecturers. Certainly in the School of Healthcare in the past, a lot of people that are involved in simulation come from an ITU background. I don't, I'm a medical nurse. But it means that sort of shapes the focus of simulation rather than what actually the undergraduate nurse needs to know. So we identified a gap in preparing first-year students for community-based care in undergraduate programmes. We also had to think about, what were the global health priorities, and we decided to focus on obesity because that was something that had relevance across the country. We had certain parameters. It had to be universal. It had to be with no ongoing costs, so we were restricted. We had a certain amount of funding, so immediately I got excited, as I do, and thought, oh yeah, we could do virtual reality, we could do all this augmented reality, but actually we didn't have the budget to do that. So we ended up using video as the platform because it was universal. So I'm not going to talk too much about authentic learning, but there's just a slide there talking about, what it is. It's about, reflecting the way knowledge will be used in the real world setting. And what we know is that authentic learning contributes to student satisfaction. And if you look at our national student surveys, students often say, we want more simulation, we want more simulation. This is the bit that they enjoy, so it's really key. So
I'm Chris, and I'm part of the teaching team that delivers this kit. And really, as Claire said, it was around that sort of gap in community practice, really. So my background is mostly community. So there was a team of us sort of came together, and actually, originally, the kit was developed with students as well. So as part of the teaching, it was deemed that we would be looking at, students found it difficult to adapt to a community setting. So that's why the video was developed, and we looked at the kit actually gives you the whole sort of scenario, really. So there are 8 clips to the film, and from a teaching perspective, it was around, we have small groups, and we have discussions between these 8 clips. So the students obviously, really enjoyed that because they were in smaller groups, could speak to each other, and they felt as if their voice was heard, really, and they felt valued. So really, it was about that co-production with students originally, and then that development then of looking at what we need to focus on in relation to community nursing when we go into patients' homes.
as I say, students really struggle with the adaptation, don't they? Oh, I've gone the wrong way, sorry.
Yeah. So the students like the quality of the video as well. So because it was a project that sort of very much money went into it, so we could actually develop an authentic sort of video as well. Hand in hand for the teaching staff, the nurse kit, which is actually this. So it's deemed that we are a sort of community team that delivers, the teaching, but actually there's so much detail in this, and I think any other sort of lecturers with no community background, could be sitting in and sort of adopting it because it's there really very clear. You've obviously got, your learning outcomes, in the nurse kit, and lots of suggested use of the film resource as well. So.
Okay. Just to add in, we used a standardised patient and a production company to produce this. What you'll see is this is an actor here, and they're wearing a bariatric suit, so they're not actually. We've actually managed to purchase that out of the money, so we can use that and integrate that into any teaching to make it authentic. So one of the outcomes of the project was to evaluate it. So we, in Cardiff, had the most numbers in terms of evaluation, but it was evaluated across 3 universities, the university in Italy, Finland and here. But I would say the bulk of these figures come from Cardiff. In a nutshell, it was strong, highly evaluated. Students were really satisfied using it. Was sorry, that's me fiddling. It was students evaluated using the simulation experience scale. They also did a survey pre and post, which measured competence, and actually it had 75 items. I have to say, I don't have much faith in this. And one of the downsides of doing, a project like this, an international project, is that you have to sort of agree on things. I have to say I wasn't convinced on the use of this scale. It was very burdensome for students. So I would take those findings about significant improvements in competence with a pinch of salt, maybe. In terms of the impact, though, we ran focus groups of students and facilitators. It was highly evaluated. Students particularly liked the high quality of the film, and we've done a lot of filming in the School of Healthcare for clinical skills education, and one of the things that came across is they thought it was a really high quality resource. This, as a learning resource, has now been integrated into our curriculum. It's also now an open access resource across the UK and beyond. And just really thinking about the impact, a similar approach could be used in other programmes where you're trying to sort of encourage students to think about professional behaviours or thinking about how they might adapt to different environments and what those issues might be. Sorry, I'm
going to have to stop
really
you there.
Fast.
I know, it's a shame because I'd quite like to listen to everyone for 15 minutes, but otherwise I'll get in trouble. So can we have Di up next?
I'll be kind and put yours straight in.
Thank you, Claire. Okay, good afternoon, everybody. I'm going to talk about a session that involves pharmacy students in their final year taking a medication history. And it's a very small group, and you'll find out a little bit more about while I'm sitting there being interviewed and questioned by final year students shortly. And I'm talking here about my pharmacy job rather than my dean's job. So in terms of the session itself, it involves students preparing for an assessment whereby they have to, from a simulated patient, an actor, take a patient history with the examiner in the room as well. That's a standard form of assessment for assessing these types of skills. So during the consultation, I was the patient, but also the academic. And the medicines I spoke about were my own and how I take them. So the authenticity came from me as an individual person, believe it or not I am, even though I'm the dean. But also, it was a safe environment. So they, between them, asked me the questions about my medicines, and also at that time, I was able to provide constructive, in-the-moment feedback about the wording of a question or the order. And then students were told as well they could ask me anything they wanted to about my medicines that perhaps they wouldn't want to ask a patient. So why on earth would the doctor prescribe that for you? We excluded social history from the consultation due to a lack of time. So prior to the session, students were informed of all this. They had to give their written consent, they'd keep the information confidential, and they weren't told prior to the session that I was the patient. They were told the patient has this, this and this. And then after the session I told them to keep that quiet. And I would say 90% of the students were surprised when they came into the room and looked for the patient and they weren't there. They were given my list of medicines in advance, my regular repeat medicines, but not other things I may be taking, creams I may be using or things I may be buying. And then I told them beforehand, but after that session, within 24 hours, I wanted them to email me one thing that they would change as a result of that session, either to prepare them for a forthcoming clinical examination, or for the problem-solving final paper, or for practice. And then I said, and you can see this in red, that is, you will use your learning and the feedback provided to help prepare for future assessments. So again, a subtle message of reinforcing that the conversations that we're having, it's actually feedback to help prepare them for assessments. So here are the intended learning outcomes. So patient confidentiality in accordance with our regulator, a full medicines history, identify issues during the session, pre-session, and then as part of that negotiation with the patient, then we would develop potential solutions. So it's also about working in partnership with the patient as well as what happens in practice. Importantly, to reflect then afterwards about their learning and how it could influence their future assessments and practice, and then use that feedback to help support them as well. So I evaluated this in 3 different ways over a 3-year period. First of all was quantitatively using a standard school survey about was it interesting, was it useful, those types of questions, and was pleased with that score. I didn't round it up, that would have been unfair. Peer review comments, I've had 5 different colleagues in the room reviewing me, not participating, but reviewing, and their comments were, it was safe, it was supportive, it was authentic. The feedback immediately was incredibly helpful, they thought. The learning from their own questioning, but also importantly, those from the other students, things the other students did well and things the other students didn't do so well. The challenge, of course, is staff time and sustainability, because I do this 25 to 30 times every year. But because of the quality and effectiveness of the teaching session, that's important in terms of the student learning. So I've got rid of a lot of my other teaching, and now I use it as online learning that they need to do, but it's not taught to them. So in terms of evaluating the second part, the third part, the students emailed me some of their comments immediately afterwards or the following day. And what I did is I put them all in a file, anonymised them, and I told them this, and sent everybody's feedback to all the students prior to the communications assessment and towards the written exam, so they could pick up the learning from all of the students in their cohort. So they started thinking more about non-pharmacological interventions, which is a positive thing for pharmacy students who are very much medicines focused. Really useful, especially when considering how to word questions, because sometimes you might say to somebody, oh, how are you getting on with these medicines? Or what side effects do you get with drug X? How does the patient know that they get this particular side effect with drug X? So it's about the wording. And the real-life patient helps to put things into context. They also felt confident about ability to phrase questions to ensure that the answers that they were getting were more reliable about the precision of the questioning. Challenges in terms of the degree in MPharm, very limited clinical exposure, unlike healthcare sciences, medicine and dentistry. We probably have 2 to 3 weeks in total in clinical practice in a 4-year degree. And so what we have to do is to increase authenticity wherever we can within the programme. Sustainability is a problem, but because of the value, we're going to keep it. Thank you.
Bro, thanks. Next up, we've got Liz Metcalf from School of Medicine.
And likewise, I'm going to...
Thank you.
Is that the right one?
It is. Just get it onto the right bit. So, I'm Liz Metcalf. I'm a GP working in the School of Medicine as the Director of Assessments and lead for clinical assessments. Heard a lot about teaching. I'm going to take a bad cop assessment focus for this short discussion. What I want to do is give you a little short overview of how we're using role play with both real patients and actors within our clinical assessments within Medic, and think about what effect that's had on our exams. And then bringing into the discussion at the end how you might apply the principles we've used within Medic into your own assessments. So the key ethos of our undergraduate 5-year course is that students should be taught, practiced and assessed in authentic tasks that we would expect of newly qualified doctors. That's the sort of the headline statement there. So in designing our assessments, we have to be incorporating patients because they're kind of important. About 5 or so years ago, we moved from a sort of more standard OSCE format of clinical assessments to an integrated structured assessment. Rather than students being asked to be assessed on isolated tasks, which really didn't link to anything relevant, we were asking students from the earliest clinical assessments to be thinking about what's the patient presenting with, what do they need, and what am I going to do about it? And so that has gone through our teaching and therefore is mirrored within our assessments. Students do these summative exams at the end of year 2 and year 4, and then in year 5 their clinical assessments are purely workplace assessments. We give them opportunities for formative practice exams, expensive but much appreciated by the students in terms of their preparation, seeing how they're learning, getting feedback and helping them get ready for the final exams. We use about half and half real patients and actors within these assessments. In general, if the students are examining patients, then we'll use real patients because we want them to have real clinical signs that the students should be expected to find. Sometimes we ask the real patients to do some role play, but generally more of the role play is on stations with actors. Using actors within the exams allows us to assess skills which you wouldn't be able to consistently, reliably do in a summative setting with real patients. It just wouldn't be fair. Breaking bad news, that sort of thing. It's really important, I think more so within assessments than within teaching when you're setting up using patients and actors, thinking about their equality and diversity training, the standardisation, consistency, as you would your clinical assessors. The patients and the actors play a key role in the exam experience for students. And the patients also contribute to feedback. They can give a very unique perspective in terms of what was the student interaction like for them as a patient, their professionalism, their engagement, communication and so forth. So it's really important just to be clear what sort of the agenda is for the patients in that setting. We're not very high tech. We've got 320 odd students per academic year, and I'd love to have a fancy skills lab that would accommodate everybody, but we use the sports hall with poster boards. Actually, once you're in your little pod with the kit set up, it's okay. You can believe it's probably, I can't be rude about my GP surgery, it's probably not far off the equipment in some of the GP surgeries. The boss is at the back. We will use, where possible, clinical resources that are authentic, so the news charts that the students are using on the wards, blood results, x-rays, so forth, as close to what they would expect across all Wales placements as possible. We then get sort of slightly detached kit for some isolated tasks, but actually our main assessment of clinical skills is on real patients, okay? In the workplace when they're performing venipuncture and clinical skills, they're generally assessed within the workplace. Can't read my own slide, what did I put? So, thinking about the impact of the impact of how we've been able to use the role play and simulation. There's no question students aren't keen on exams, I'm not going to lie, but I've found some students actually can see the value of this integrated approach, that it's actually giving them a chance to demonstrate their skills and show what they've learnt and what they can do, whereas they may not have that opportunity with a written exam. There's work to be done there is no question, in improving the student experience. Talking in terms of patient safety, making the exam valid, real life, we can mimic any clinical situation pretty much within the ISCE and replicate that consistently across 8-10 parallel circuits by using actors who have a lot of training and ensuring that they're consistent. I think the exams are very reliable in terms of assessing what we set out to assess, and
we triangulate again with our workplace assessments throughout the course. The patients get to contribute. A lot of the patients feel that's very valuable, and we are also providing employment for actors, giving them a sort of a contribution. It's most relevant and highlighted by a company we work with, learning disabled actors. They really value this role that they have within our students' teaching and assessments. So, opening really into the discussion for at the end, I think it's a question of thinking about what's your assessment trying to achieve if you're going to bring role-play and simulation in. What are your learning outcomes? Can you be assessing them other ways? Is this the best method? It's expensive, it's time-consuming, but if it is the best method, how are you going to best use it to ensure consistent experience for the students, feeding forwards from the assessment so that they can actually use their feedback as we've got the patient feedback, so that it's not just a hideous challenge for them. Okay, that's it.
Thanks. So next up, we've got Emma Pope from Healthcare.
I have slides. It's all right, I haven't got any slides. I go, no, school is just me. So I'm not Dr. Liz Metcalf. If there are any questions, please direct them to Liz. I kind of feel like everything I wanted to say has been said. I run a third year module. My background is in radiotherapy and oncology. I run a third year integrated theory and practice module. And part of the assessment for that module was always designed to be a real life experience of a radiotherapy review clinic, where our students are able to give advice, listen to, interact with a patient in a real world environment. When we sat down and tried to map our third year clinical experience, we ended up with 12 weeks of clinical experience, which you think, okay, we've only got 20 students, we can manage that. But we only use 3 centres in Wales because we've only got 3 clinical radiotherapy centres in Wales. So that means we've only got 3 radiotherapy review clinics that we can use. If we're going to give our students enough opportunity and time to learn and develop the skills on the job, they need at least 3 weeks each. We can't squash that into 12 weeks of clinical placement. So we've taken it out of the clinical environment and back into the university environment. And when we were designing the assessment, very much my key thoughts were about constructive alignment. How do we make sure that how I'm teaching will feed into that assessment at the end? So the assessment, the end point, is a 15-minute practical session between a patient, a patient actor and one of our radiotherapy students and an assessor in the room, pretty much like Professor John was saying for his pharmacy students. The assessment assesses several core skills that we want our graduates to be able to do. It assesses that excellence in communication, and it assesses their ability to offer appropriate and relevant advice given what is being presented in front of them. In order to align all of these, we teach it via practical teaching methods. So my student body is divided into groups of 3. They work in triads. We have confidentiality and we have contracts within the teaching sessions so that what is said in the room stays in the room to make it that safe environment. When they're working, we have one of them, or when they're practicing their skills, we have one of them as a patient, one of them as a practitioner, and one of them as an observer. So they get that continuous peer feedback of the interactions that they're having, and then they have feedback from myself, and I will periodically drop in and play the role of the patient as well. And that gives them a more authentic learning experience. What we're getting back was we used to do the assessment with members of staff, and our students said to us they found it very difficult to get into that environment, to get into that authenticity, because they knew who we were and they couldn't believe that we were patients. Didn't matter how good our acting skills were, they knew who was going to be there. And therefore we went away from that. We tap into medicine actually, and we use the medicine actors. They come in, means that we have some consistency, although there is some variation, but the students do. They deal with whatever the patient throws at them at that particular point in time, and I think I'm probably up. And that's what we do.
Great, thanks everyone. If you'd like to come and sit on the front, or would you like to have questions over here? Come on, actually, because we have a microphone to pass around. Right, someone can take this. Take this banner. Go on then.
Should I sit on the floor? Oh, there's a stool. No, here we go.
Great, so if anyone's got a question for anyone, let me know. I'll bring the microphone over.
What Emma just said about having the lecturer or the tutor there acting as an actor, would actually, when you presented your case, that was my thought. How authentic would it be? Because if a student is seeing their own lecturer or tutor there, would really not make them feel that learning authentic. And my question was going to be this, but then Emma's answered my question saying it's best to have actor patients.
Actually, in the teaching sessions, they value the lecturer playing the actor because they then think that's more authentic than one of them playing the patient.
Okay.
But in the assessment, they want us sort of removed because we put them off.
Yeah, I think that's the better way to do it, because then you can see them really coming out. Because working in the School of Medicine, I know the actor patients, students feel it's safe working when the actor patient is there rather than one of their lecturers or tutors. Yeah, thank you.
Can I ask probably Michelle a little bit more, but can I just ask about the role of debrief in these kinds of situations of simulation? I think it might be relevant to others as well. I think obviously if it is not a formal assessment, obviously they have feedback, but if it's part of learning, do you debrief? How do you debrief? And do you find sometimes that actually the experience reduces students' confidence sometimes, or have you come across that?
We do debrief every session. It's not an assessment. This is just a learning tool, I suppose, forum theatre. But it's essential to debrief, especially if there are some errors made or poor practice highlighted. But we do it very sensitively, actually. And the students, there's almost like peer support, I suppose, within that situation. But we do debrief and we signpost them to the relevant theory or organisation in relation, obviously here, honour-based violence. But debriefing is essential. And we also use that opportunity to get feedback from the students initially. We ask for more formal feedback in the way of a questionnaire, but I didn't have time to say about the feedback. We've had different feedback over the last 2 years, actually, and some students want more information about the process before we go into it. But that's not the beauty, I suppose, of forum theatre. You throw yourself into it. Otherwise, they won't. They're very nervous about role play. So we debrief around that as well. But from a practice perspective, we hopefully signpost them and build their confidence, because it is a difficult situation. But we give them lots of time to practice asking that question. If Kate exposes her bruise slightly, how would you deal with that situation in practice? Would you leave that victim? They say, no, but what would you do? Would you call the police? So we do debrief in quite depth, actually, for this session. We allow 3 hours for the session. It's a morning session. Make sure it's morning, because it's quite a complex situation to offer that debrief opportunity.
Just to say, debriefing is a key part because we are quite convincing. Sorry, just to say, debriefing is a key part because we are quite convincing as actors. And you can see the students are a bit reticent to ask a question because they still think I'm the scary mother-in-law. And we have to emphasise that we've stopped acting now and we are back as lecturers. You can pose a question and it's a key part.
It is a challenge stepping out of that role, especially for Kate. Especially for Kate and Diana, because Kate's very quiet, so she's very manipulated by Diana. She does it very well. I think both of them perhaps should be in theatre themselves, but I've got the easier role as the health visitor, I suppose, but they do that very, very well. And the students evaluated the whole session at the end of the programme extremely positively, but gave us some useful feedback. I'll share with you that I would say, oh no, nobody's going to stand up. They're afraid to stand up now, get involved. So I was almost reinforcing their fear. So we've learnt a lot, haven't we, from their feedback, and we're making subtle changes on a yearly basis.
I think there was a question at the back. I saw somebody.
Thank you. Can you hear me? Okay. I'm Graham from History, Archaeology and Religious Studies. And I was thinking about, I do careers and employability in our school, and I teach on an employability module. And I'm trying to make interview training fun and not threatening. And one thing I would like to do is to get the students to answer questions, to do some role playing. And my question to you is, how can I do that without them getting really anxious? I mean, as an example, and it's nothing to do with work, but I ride a motorbike, and I think I ride it quite well. And the other week, I went on a police course, and as soon as I knew a policeman was behind me, right, assessing my riding, it was terrible. and so many mistakes. Apparently, I was threatening the drivers in front, but we won't go there. But, how do you overcome that fear and anxiety? I assume the students have a lot of practice up to their assessments, so they're used to being in that situation, are they?
Sure. So I think you've hit the nail on the head in not throwing students in to a summative assessment without having any preparation for it. So I think it's how you can develop the students, not just in that module, but throughout the programme, so it almost becomes second nature for them to ask questions, and they've had all the feedback prior to coming there. So think about introducing something that's low stakes initially, perhaps formative, and then with a view over 2 to 3 years to building towards it would be my suggestion. There may be others.
I would say use their anxiety, because when you go into a job interview, it is an anxiety provoking, so use that as part of their learning. So maybe do just throw them in the first time, but actually then spend that time debriefing and having the discussion. So how did you feel? How do you think that impacted on you? What could you do differently to make it different?
I have a little suggestion too. Video them so they can see how they're coming across. If you've got the resources, is useful. But also when you're going around starting how to give feedback, ask them what they want the feedback on, what are their little insecurities, and then you can target that and then address other issues, and that again helps build their picture generally.
I usually only got 50 minutes.
Yeah.
This is the thing. I mean, I'm used to training in employability and having a day just to concentrate. But our lectures are in 15-minute slots. In 15 minutes, I've got to turn them into really brilliant interviewees.
What I was going to say is we... Is this on? Yeah. Doesn't sound as if it's on. We couldn't show you, we didn't have enough time. I'm going to moan about the time, but we didn't have enough time to show you the video. But actually, that was a poor example of professional behaviour of that student out in the community setting. And sometimes, actually, we had a lot of discussion about whether we should do a bad one and a good one, so students could see. But actually, they learnt more because we were talking about, the bad points. And sort of following on from what you were saying, some of the anxiety you could recreate, an interview that doesn't go well, and that creates a lot of discussion, and they can see that for themselves, what, that wasn't right, and you can create a lot of learning and a lot of discussion around it. What do you want to say?
I'm fine, thanks.
You've all said something now.
I'm fine. I'm absolutely fine.
Okay, we've got time for one more question if anyone's got one before we...
Wendie Ivins, Computer Science. We don't use Roleplay at the moment, but this looks like something really great in preparing our students for either for working with clients or dealing with difficult ethical situations. But what I'm quite interested in is, if we've got a class of 180, how do you start with scaling this up and being able to do this when perhaps initially we're not going to have the resources to do this in a way that healthcare have been able to do?
It's challenging in a nutshell. But in terms of the student experience, it's very valuable, it's very authentic. And the students love it, don't they? But yeah, it is difficult when you think about some of the things that you have, in terms of workload model and, the drive for efficiency, and then you've got authentic learning, and sort of they contradict each other, don't they? So it is difficult, but I think that's what students value. So as lecturers, we value it in healthcare.
Can I say something? Sorry. So with the nurse kit, we have about 25 to 30 students. And there's not that many of us that need to facilitate that. We obviously do quite a few sessions over, say, a week, depending how big the cohort is. But it seems to, work very well. And like Claire says, the students really appreciate it. And like I mentioned, they feel very valued because they feel a little bit more safe because there's less people in the room, maybe a bit more confident, So it really, really works. So it's worth sort of pursuing. But the other thing to think about is how you do it sort of creatively as well. Like we use a video, and we can, have 25 to 30 students in the classroom, but equally, you have triads. So there's lots of different ways. So it's what sort of resources you can tap into, really.
I'd just say decide key learning outcomes or skills and just focus on them. And you can start big groups. We started in Medic 20 years ago with comm skills. We'd have groups of 30 with just one actor. And over time, we've been able to build up to groups of 5 or 6, each having a go. But you can start, sort of in the bigger group, but just focus. What are the sort of 2 or 3 key things rather than trying to do everything?
I'd say think about, can you tap into anything that we've already got? Even if that's us as resources to, come and help, come and have a chat, anything like that. And I think that's the way you kind of just build the ideas. I nicked mine originally from comm skills in Medic. I'm just going to put that out there. But I've developed it.
Dealing with difficult patients, difficult customers, or, whoever your students will be interacting with. Hello. It's key central messages, and there are lots of resources out there in a clinical context on YouTube and so forth, and it maybe sort of have a filter through and then see either use them or what you can mimic yourself.
I take my hat off to you, because in healthcare subjects, we do that all the time. You're thinking outside the box, how you can introduce something differently. I would suggest the way we introduced in professional education was to pilot it as a voluntary activity first, and then try and incorporate it perhaps to some of your labs. So somebody goes round and just raises a question, and then see how that goes down, and then you may build up people behind you willing to contribute, and then go on to the groups of 30 or 40, and then perhaps the large groups with other materials, and it will help make them think, I think. So I would say be brave and try something. Better done something than not done at all, if it doesn't count towards the degree.
Great, thanks everyone. We're out of time now. The next session is starting in about 7 minutes. We'd just like to thank everyone again for being part of this session. And if anyone wants to follow up with anyone today and they don't get a chance to catch them, send us an email at the CSI and we'll put you in touch with the right people.